in malperfusion patients rapidly restore flow and pressure into the true lumen. So let me just share with you some data from a study that was just done in the United States. It's called a Persevere Pivotal IDE study. It is not currently available in the United States commercially. It is only available as part of an IDE study. We're hopeful that within a very short period that we're going to have approval in the United States, but we're working with the FDA to hopefully make that a reality to better serve our patients. Here's a video of how to do it, and I know we're going to have a hands-on session here. This was actually our first case, so I think this establishes how straightforward it is to deploy. Again, as I mentioned, integrate deployment at the time of circulatory arrest. Under direct visualization, this slight pre-curve delivery system allows you to atraumatically advance this in the distal aorta. And note, this is a zone 0 anastomosis. This, you can see the head vessels are completely not visualized because we're in zone 0. This is a distal ascending aorta. So for a lot of surgeons who may not be comfortable doing an extended arch, this might be the right operation in those surgeons' hands. This double cuff felt layer technique was taught to me by Michael Moon, probably arguably the person in the world with the most experience out of Canada. This technique allows you to do this reproducibly with a very low incidence of day. Once that cuff is secure, you can see here the stent is then deployed, fairly straightforward, by pulling the cord. Now you can see here, using a running suture, incorporating the external felt, as well as the PTFE cuff of the device. This allows you a fairly efficient way to establish a distal sewing site for your distal anastomosis. As you can see here, and you can imagine, it's quite hemostatic and is very effective in preventing DANE. You can look down there and you can see the stent and you can see the arch vessels. So again, zone 0 anastomosis. And then I think for most surgeons who may not be comfortable with doing an extended arch, this is certainly an anastomosis that most trained cardiothoracic surgeons is able to do. Just some data for you out of the trial. The trial has completed enrollment November of 2023. You can see here 26 sites, 2 30-day co-primary endpoints. Number 1 being percentage of patients with greater than equal to 1 episodes of major adverse events as defined by mortality of 30 days, new disabling stroke, renal failure requiring dialysis, and MI. And the second co-primary endpoint is percent of patients with DANE. Using historical retrospective control groups, you can see here the MAE endpoint goal was set at 58%, and the DANE endpoint was set at 45%. Again, historical controls here. This is a sick group of patients. Malperfusion. You can see here about 80% of patients had evidence of clinical malperfusion, while about 20% had only radiographic, severely compressed true lumen. And a significant number of patients, over half, at 55% to be exact, had multiple beds of malperfusion. So this is a really sick group of patients. Most being common peripheral malperfusion, renal, and followed by almost 40% visceral malperfusion. So all of you know visceral malperfusion is probably one of the highest predictor of poor outcome. So again, a sick group. I think this highlights what complex and how sick this group of patients are. The majority of patients, almost 85%, had a concomitant procedure in addition to the arch procedure. You can see highlighted in red. Again, I think it stresses the elegance of this technique or this delivery system. The deployment time median was 4 minutes, with the implantation time total at 15 minutes, with a circulatory arrest time of 28 minutes. It certainly does not add to the complexity. And I think this again stressed the fact that this is not a total arch reconstruction. This is a hemiarch or an open distal with an extension or an adjunct with NDS. The data was quite impressive. You can see here when it comes to the first primary call point, incidence of major adverse event with a goal of 40% and our control group at 58%. The persevere group highlighted in green outperformed the control group significantly. significantly reduction at 28%. Very impressive. Number two, it also beat the secondary coronary time point, a goal of 10% in patients with Dane. We did not see a single patient with Dane at 30 days. Also very impressive. Although not powered individually as a single point, all-cause mortality, again, the group of patients with malperfusion was less than 10%. This is the best data we've seen out of this group of patients in the United States for sure. This is quite impressive. Less than 10% single-digit mortality in patients with malperfusion. Remodeling, more data will need to be seen for us to make definitive comments, but certainly encouraging early on in terms of remodeling. This has some benefit potential as well moving forward, but more to come. Okay, so let's get to the point, that's why we're here today. I think all of us, you want to get your hands on a device, play around with it, and I want to talk a little bit about sizing and implant technique to kind of go through it again, anticipating for us in the back table there. There are four sizes, 2 straight, 2 taper. Sizing is based on a static view of the pre-operative CT scan, you can see here. We do recommend, as best as possible, a CT scan angiography to allow us to get these measurements. We refer it to as D1 and T2, but really you're looking at an axial orthogonal measurement in zone 1 and zone 4. I think those are the two areas of measurements when you look at a CT scan to help you size. Again, another, I think, comment regarding the elegance and the simplicity of this device in terms of user friendliness. I think most of us are comfortable doing this without the help of a radiologist. I could be wrong, but again, in the middle of the night when you're doing this emergently, you want something that's extremely straightforward and user friendly. You're not going to have time to play around with Terra Recon, Fremencio, whatever platform you're comfortable with. This is get it done and help the patient. So measuring again here, as I mentioned, zone 1 and zone 4, the total diameter, including true and false move. Here's the sizing, and I would encourage all to be not aggressive with oversizing. I think you stick to the IFU. You can see here the concept being 4 devices, 2 straight, 2 taper, the 40 and the 55. Each coming in a taper platform, 40 to 30 and 55 to 40. And you can see here, measuring your diameter D1 and D2, the break point is 35 millimeters. Below that, you're going to go with a smaller device. Above that, you're going to go with a larger device. Again, very user-friendly, straightforward, efficient when it comes to case planning. I'm going to go through this again quickly. You saw the video, but hopefully this artist rendition will give you more clarity. Key point here that we learned, this is an open distal anastomosis. This is not your classic aggressive bevel hemiarch. That is important for us, for you to keep in mind. You want to leave about a centimeter of cuff proximal to the BCT or brachiocephalic, because you're going to need that distance for your cuff. And again, the key here is that it's a straight orthogonal resection, not a bevel, because you can get into trouble on a lesser curve if you cut out too much tissue. So I think that's a key point for you to remember. This is not a traditional hemiarch. This is really an open distal anastomosis. You saw in the video, step 2, you introduce the device in the true lumen. It's not directional other than pre-curve because it is equally shaped 360. Once you have that in place, you then retract the collar, the protective sheath, to fully expose the PTFE cuff. I think these 4 tacking sutures at 12, 3, 6, and 9 o'clock helps. It allows you to stabilize the device, and depending who your help is in the middle of the night, whether you have an experienced co-surgeon or an experienced PA, or in some cases, a not so experienced medical student, you can do this, okay? 4 tacking sutures allows you to keep the device close to where you need to be. You deploy by pulling the cord, and then using a running suture. I usually use a fluid with a larger needle. The key here is you want to have through and through bites through the PTFE, the aorta through all the layers and through the external wrap cuff. And this is your most effective way of preventing gain. You want to make sure you do not cause any new entry tears, and this gives you a hemostatic, very robust cuff to sew to. And then once you do that, as you saw in the video, this you can see here, you can see down into the lumen, you can see the bare stents, your arch vessels, this very robust circular, not a hemiarch, a circally open distal. And now this allows you to do your traditional open distal anastomosis. Very straightforward, zone 0 anastomosis that I think most surgeons are very comfortable with and very good at to help save the patient, life of the patient who presents with severe malperfusion. Okay, I'll end there. Happy to answer any questions.
Thanks, Professor Cito. Just wondering, I saw from the data, the RCP and the ACP percentage is 50-50. And just wondering, because with the stent in place, it would be pretty difficult to put in a selective cerebral catheter through those stent holes.
Actually, I think that's a great question. I'm gonna see if I can pull this up. Sorry. There you go. Is there a pointer? This is a pointer. Which one's the pointer? Middle. Thank you. So this hasn't clearly demonstrated, but you bring a great question. It was 50-50 RCP, ACP. I think it demonstrates the variety or the variability of how surgeons in the United States are still doing dissections. I still I prefer moderate hypothermia with ACP. That's my technique. But a lot of surgeons in the US, as you saw yesterday in the presentation by Dr. Ehrlich, a lot of surgeons are still doing RCP, deep hypothermia in the United States. And I think it speaks to the variability in surgeon experience in the United States and the wide spectrum of surgeon expertise taking care of these patients. In the US, the median number of dissections done per center is 2 a year. You think about that. I mean, if you're only going to do 2 arches a year, you're not going to be doing a complex arch, moderate hypothermia, 28 degrees ACP. You're just not. You're going to do what's safe, which is go in cold, turn the pump off, and do RCP, and so. But to your point, there are a couple of options if you choose to do ACP. Obviously, axillary. I'm so sorry about that. We have done, and these cells are fairly large, and you're going to get your hands on the product. You can imagine that under direct visualization, you can put a cannula, pre-curved tip, and cannulate both the BCT and the left common carotid. We've done that. So absolutely you can. But I think early on in your experience, if you're concerned about that, I would just start with axillary cannulation, so you know you don't have to worry about it. But we have had multiple surgeons describe his or her technique of directly cannulating the ossities, head vessels, or providing ECP. So these are large cells. You'll get your hands on it.
Thank you, Dr. Cito. I'm Terry Chen from Taiwan. So actually, I have a question about the LT remodeling, because usually when we're trying to do the testing of our hemiarch replacement, actually DBMR, I know maybe in the future I have to do the total arch replacement. So in your research, I'm not sure what's the LT remodeling rate, or even the force movement decrease to the normal size, or what's the rate. So maybe in this case, kind of patient, if we put this kind of stent inside the patient, but maybe in the future, if we need to do the total arch, I'm not sure maybe this stent will be, explanation of this kind of stent will be some disaster or something. So I'm not sure. What about your experience about LT remodeling?
I think it's a great question, and you're absolutely right. Taking it out was a disaster. I've never done it, I've read about it, and I would never want to do it. So to your point, and I was discussing with our team earlier today, a couple of key points. One, as I mentioned, this device is designed for a tear in zone 0. Please do not put this in a patient with a zone 1 and zone 2 tear. That will not work. 2, in the bigger picture, you're 2 in the morning, a patient with malperfusion, really, really sick, unstable. In most of our hands, except I'm not sure you're superhuman like Professor Song, you're not going to be able to do something like this safely. You want to get the patient out of malperfusion. Do the quickest operation you can, and you do this. You get them out of operation. You get them out of trouble. The data does suggest that in the right patient, with not a lot of secondary and primary tear sites in the distal aorta, remodeling the arch has actually been quite effective. However, less so in zone 3 and 4. So what does that mean to me? That means that if remodeling is positive in the arch, but it worsens in zone 3 and zone 4, your redo is a T-bar, not open arch. In the Europe experience, there have been actually branch devices in zone 2 and zone 3, and actually zone 0, nexus, where you can rescue an arch completely endovascular with branch devices. Now, if endo option is not an option, surgical rescue has also been described and fairly straightforward. What we've done in our pen, there were 2 patients in retrospect that we should not have implanted AMDS because there was a tear site in zone 2 that we missed at the time of surgery. They both came back for open, redo total arch, but what we did was we left it in place, we did not explant, we debranch, and we did an elephant trunk. Very, very straightforward. Now, I don't have access to Evita in the US, we have access to Floraflex. So the redo total arch was actually straightforward. You sewed a cuff of the AMDS in zone 0, you branch the head vessels, and you deploy whatever platform you have for those in an elephant trunk. Great outcome. It's actually a pretty straightforward procedure. So I think you're absolutely right. I think those questions are key. It's about patient selection and rescue and bailout. And I think this allows you to do that. Big picture, you do what you can to get the patient out of the extremis. And if you're not an experienced surgeon, this is best tool you got. 3-4 years later, aortic arch blows out, then you can electively send that patient to someone who can do an arch procedure with good outcome. And if it's yourself, great. If not, you can send the patient to Korea. And and I'm sure they'll be appreciative of that. But I think that's the big picture there, is how to get that patient through that initial insult and with the best outcome you can at your center with your expertise and your comfort level.
Yeah, just a comment for integrated cerebral perfusion. So in Singapore, what we do, we snare all branches, and if you're on axillary artery bypass, you can do unilateral, and if you want to do bilateral, so you can put a lot of devices through the checks. So the retrograde cardiac picture cannula can go through, the crude catheter, smaller one, also can go through. So I think it's not a problem to do ACP with this device. And only another comment about the longevity of the device, and what we notice if you have dissection of the great vessel and you suspect you have a potential re-entry point at the large vessel, like in an innominate artery, you can still debranch it and using this device, but still implanted zone 0, but you must debranch, you must interrupt the innominate artery where your potential re-entry point gonna be. Yeah.
You have a fair amount of experience in Singapore, correct? This is something that's available to you or no?
A few dozen, so we don't have too many.
No,
Doesn't help.
I thought you said 2,000 too. I was like, okay, he's being really humble. But I would agree with you. I think that secondary entry tear, especially at the base of the left subclavian, because that's so far down during your reconstruction, can be a problem. There have been reports where the false lumen flow based on that entry tear in the left subclavian can be treated percutaneously with coils. And once you coil that back door and you seal that false lumen flow, remodeling becomes positive. The bottom line, I would agree with you. The data on remodeling and the verdict on remodeling is still out. I'm not convinced just yet, to be honest with you. I think the biggest value of this device is one, the simplicity of the implant. I always hate to talk about arch surgery as simple, but when you compare it to an extended arch, it is absolutely more straightforward. And 2, malperfusion. I think the sweet spot for this platform is treating patients with malperfusion, because it opens up that true lumen very, very effectively. And that's what you need to get these patients out of trouble.
Yeah, thank you, Dr. Chetro. It's a very excellent presentations. I have many questions. The first one is about the sizing. if I show you like the slide right, the sizing was based on the total external diameter, right? So I think it carries some risk of oversizing, and actually looking at this device, the distal part has quite a large diameter. In my data, looking at my own patient, the disamniotic diameter at the complete remodeling is always less than 30 millimeter. The average is about 24, 25. So if you size the device based on the total diameter, not on the true lumen, it may carry a risk of oversizing. So
I think that's
my first question.
Yeah, I think that's a great question, Professor. I mean, I would be concerned as well. And as I made a comment during this slide, I would caution against aggressive oversizing. A couple of things, reasons why, what you just discussed. You can actually cause more than help. And two, there's some preliminary data that suggests that if you oversize, you can actually cause compression of the device. What does that mean clinically? We don't know yet. But you can see here, even though the device here, as you can see, marching from left to right, even though the device is called 40 millimeters, you can see that the felt diameter is actually 24.
Yeah.
So but you're right, oversizing can be something that you can do that would not be good. So I would caution against oversizing. We have not seen a high incidence of sign distally,
But
at least based on this data.
But not general.
I'm sorry?
As the instance of the sign in this series,
And this, we saw one.
just one.
One out of 93 patients.
Wow.
And that required an open thoracoabdominal surgery as a rescue.
Yeah.
There were 2 rescues, approximately, 2 total arches from unrecognized tear in zone 1 and 2. And then the third reoperation was the sign distally resulting in open thoraco.
And my second question is about DANE.
Yes.
I think it's the DANE, the prevention of DANE is another beauty of this device.
Agreed.
But I think that the DANE instance of DANE depends on how you define it. So in my experience, if the fourth lumen just next to the anastomosis is completely patent in the CT scan, I cannot say whether this patient has DANE or not. So probably it would be better to define the DANE as the complete thrombosis at the juxtanastomotic first lumen. So did you see that data like in this manner or so?
Yeah, so I think that's a great question too. And I think what we found here, at least the way the core lab defined DANE within Cleveland Clinic was what you mentioned first, which is no flow into the true lumen, no flow into a false lumen antegrade. And the majority of patients on I didn't get a chance to show the remodeling data in this talk, but yesterday, at least out to 6 months, in zone 0, 1, and 2 was very encouraging. Less so in zone 3 and 4. We saw less positive remodeling as you would expect in zone 3 and 4.
Yeah, so I think that in the future, in any kind of articles or research dealing with the DANE, I think the definition should be the complete thrombosis of the first lumen, maybe 3, 4 to 4 centimeter from the anastomosis. So I think the data should be presented like that.
Thank you. I'll make a note of that.
Yeah.
We'll talk to our core lab.
Yeah. And my third question is about the zone of anastomosis. You emphasize that it should be zone 0, but in my opinion, if there is some good lines between innominate and common carotid, we can do it in zone 1.
Great question.
Yeah, because in many patients they can have the malperfusion into innominate artery. I think that in that case it is will be better to prevent stroke and something.
Is there anybody in the FDA in this audience? So the design of this study was based on zone 0 anastomosis. But you're absolutely right. OUS, there have been now increasing experience, not only in zone 1, but zone 2 anastomosis. And deployment in EMDS in patients with malperfusion. So you're right. I think if we can extend the distal suture line to zone 1 and zone 2, perhaps, depending on the patient presentation and anatomy, I think that's another added value. We just have no experience with that in the U.S. because we have not been allowed to do so. But I think you're bringing up a great point. I can imagine once it's approved in the U.S., surgeons will likely find this valuable in patients with lumbar perfusion in the primary tear site, let's say in zone 1 in the base of the innominate. You're going to want to do a zone 2 anastomosis in the coitus.
This just, if I may, I want to add some comment because I think looking at the U.S. data, I'm always surprised that there's a very small proportion of the so-called partial arch replacement. Always they say just hemi-arch versus total arch. But from the standpoint of educating young surgeons, I think that doing one partial, two partial is a very good transitional step in having more experience of the antevated perfusion and deep anastomosis. So I think this device would be better if we can be combined with the so-called partial.
I would 100% agree with you, and I'm going to have to wait till it's approved by the US FDA. And you're right, as you know, we've shared a lot of data out of a Penn group. Ramesh Desai has kind of led this, being more aggressive with a zone 1 or zone 2 anastomosis in the management of patients with DeBakey-1s. But you're absolutely right. For younger surgeons, it could be a graduated experience to be more comfortable what you eventually do in a zone 2 or zone 3 anastomosis with a more definitive cover stent. But I think this is another tool. I think the key to a successful aortic program obviously is volume experience, aortic team. I do feel strongly about that. You have to have a robust aortic team like you do. And then technology. You got to understand that these are not competitive. I find these complementary or synergistic in many ways. And I think as an aortic surgeon, you got to understand all the tools you have and find what's best for that particular patient.
Thank you, Wilson.
Thank you.
Thank you everyone for your active participation in discussion. Well then, yes, please round of applause to Wilson. I want to welcome the next speaker, Professor Sasha Lin.